Okay, I think we are ready to jump in, and we are all thinking mostly about the exam that happens tomorrow. So remember to come and take it at some point between 7:30 in the morning and try to be done, all set to head out before 9:30 at night. That's the window of opportunity that you'll have unless you've talked to me. If you do need to talk to me, as is always the case, do so. My only reservation, and I think you all know this already, is that once we do push it off to another day, we need to make absolutely certain that it finds its way onto my calendar so that I don't somehow miss you. So make certain that it's been scheduled officially with me. And then also, I keep meaning to mention this, late work always goes on like the bottom of my pile. So I'm always more than happy to be very flexible with you submitting things late or taking your exam late. But please do know that with that flexibility comes the lowering of the priority of the grading of whatever that is. So I think that works out okay in the long run. Is sometimes it's nice to have that flexibility and you don't mind the fact that it takes me a little longer to get it done. I am working through the emails with your abstracts, and I've already been enjoying them. It takes me a lot longer to grade the abstract than it does to grade the hypotheses, so please be patient with me. I think I have chugged through 3 of them so far, and I'm working through them in order as they were received. So if you submitted early, you've probably already got feedback. If you submitted a little later, then you won't get feedback until later. I'll have to postpone or put on pause the grading of those as I turn my attention to grading the exams starting tomorrow morning. So at that point, I'll try to get your exams done and all finished off and turned around to get back to you on Thursday. Fingers crossed. Okay, great. I think that's most everything except in lab to remember to keep chugging on your unknown report. I know that at this point you probably hit pause button on that as well, just to make sure that you're all ready to go for the exam. Does anybody have questions for me? You all remember that you have your poster accessible for tomorrow. You can bring that with you, and of course have added everything on it, Lauren. Right, no homework ever on exam days, that's right, yeah. Anything, you can add anything and everything to your poster. It can include all the material that we've covered, but it needs to be a picture, right? It cannot be large blocks of text. So the only rules, right, are that it cannot be large blocks of text, so I don't want to see like Xerox copies of your notes like stuck little onto the poster. It needs to be of your own making, okay? So you have to have created it, and there are all kinds of creative ways to create it, but it needs to be your creative endeavor. And of course, what's the last one? One sheet of paper. It can be huge, it just needs to be contiguous, right? It needs to be connected. That's the only rules that I have, okay? Anything else at all? Marvelous, because I know you all want to talk about antibiotics. You've probably been spending all weekend thinking about getting back to the coverage of antibiotics. I know I was thinking about it last night. I cut myself with a knife while I was washing dishes and had to put a butterfly bandage on it and everything, and I went ahead with a little Neosporin just to ensure that it didn't get infected. So today we're going to talk about Neosporin, so that was maybe a real-life example of where this will come into play. So, oops, sorry, I kind of got behind here on where my announcements were supposed to be. This is the quick review from last time. Remember, we were talking about therapeutic dose and toxic dose and all the beta-lactam antibiotics and targeting the cell walls, and we just ended up with penicillins and cephalosporins. So I think this is the same basic announcement that I had intended to have up. So today I want to begin with another antibiotic that targets cell walls, vancomycin. Vancomycin has become a little bit famous in the face of MRSA because it's the next line of antibiotics that's used to treat methicillin-resistant Staph aureus. Vancomycin works in a way very similar to the beta-lactam antibiotics in that it also inhibits the cross-linking of peptidoglycan. But recall that the penicillins and the cephalosporins did that by inhibiting the enzyme that builds the tetrapeptide chain. Vancomycin does something a little different. It actually, while the tetrapeptide chain is elongating, it binds to that elongating chain in place of one of the amino acids and literally blocks elongation. So by itself, a very bulky, large molecule, it gets in the way of further addition of amino acids to the tetrapeptide chain. So recalling that it is very bulky and large, why is it that it is never effective on gram-negative cells? What prevents its passage, Sam?
Those gram-negative have like very thin, or it has the outer membrane.
Yes, good.
It's a very thin peptidoglycan.
Right, so what's preventing vancomycin from getting it? The outer membrane, yeah. So remember that we talked about the porin proteins that span the outer membrane? They're not super exclusive, nowhere near as exclusive as those transporters across the cytoplasmic membrane. But there is a limit to what they'll allow in. Remember we talked about 600 to 700 Daltons being that limitation. So vancomycin exceeds that. It simply cannot get into the outer membrane. So because of that, this antibiotic is never, ever, ever used to treat a gram-negative infection. It simply will have no impact. So only gram-positives would be effectively targeted when vancomycin binds to the elongating tetrapeptide chains and stops their synthesis. Only outer exposed peptidoglycan would be a potential target. Therefore, we see this being used, as I mentioned, in antibiotic-resistant Staph aureus. It's also used, interestingly, to treat infections caused by Bacillus and Clostridium. So remember, some of you had Bacillus as your unknown. So we talked a bit about anthrax caused by Bacillus anthracis. So these are some interesting gram-positives that can be impacted by this. But because of that inability to cross the outer membrane, gram-negatives are innately resistant. Now, I know that in lab, I asked this question. I can't remember exactly who told me that they'd personally experienced MRSA or had a friend or relative or maybe some exposure to someone with MRSA. Who said they had? Okay. Yeah, Michelle, I kind of remember that. So with that, what was the next step in treatment? How did it work for the person that you knew that had MRSA?
I actually had it personally.
That's right, okay.
I went to the doctor and they tried to do a normal antibiotic, but it wasn't enough. So
Right.
we had to do a more aggressive antibiotic.
Right. Yeah, a more aggressive antibiotic probably potentially meant vancomycin.
Yeah.
How were you treated? Was it orally or did you have, it was orally. Okay, so that wasn't vancomycin. Vancomycin actually has to be administered parenterally, which is a fancy word for not orally. Intravenously, for example, so you might have to go in weekly and get hooked up to an IV or something along those lines. So it's not administered orally. And that makes treatment with vancomycin all the rougher for the patient. And of course, now we also recognize that cases of what are on the rise? Versa, right, vancomycin-resistant Staph aureus. So this is a next-line antibiotic. We categorize it similarly to the beta-lactams because it does target peptidoglycan. There is one more that I want to talk about that also targets peptidoglycan, but it does it in yet another way. This antibiotic is called Bacitracin, and we've seen it before, haven't we? Where have we seen it? Yeah, good. So many good answers. Taxos, but we also see it in Neosporin. So if she's been hanging out with her Neosporin tube and thinking, what's in here? Bacitracin is one of the first ingredients in Neosporin. It is a very non-selectively toxic antibiotic. That is, said another way, its therapeutic index is very low or high. I was ripping out these strings of Friday memory. What was selectively toxic antibiotics? Did they have a low or high therapeutic index? High. So this has a very low therapeutic index. Yeah, so therapeutic index on Bacitracin, horrible. It's very low, very not selectively toxic. And this is because it inhibits transport of peptidoglycan precursors across the cytoplasmic membrane. Now, seemingly seems like, well, that's okay, right? We don't make peptidoglycan. But if it inhibits transport fairly broadly, you can see why that would have a negative and deleterious impact on the host as well. So bacitracin is not an antibiotic that you would ever swallow orally because it is not selectively toxic. But on the other hand, putting it into Neosporin works pretty well. So the first ingredient that we might find on our topical triple antibiotic ointment, if you buy the generic, you'll have noticed that it's called triple antibiotic ointment. So today we're going to meet all three, beginning with bacitracin. Only used topically. So last time, in addition to thinking about the fact that peptidoglycan was a good target to selectively inhibit bacteria, we also, and I want to say it might have been one, Trey or Levi or DJ, somebody up here, that said that we also target what is uniquely found in bacteria. Yeah, the 70S ribosomes, right? So the 70S ribosomes are another target. That's actually where we want to take our attention now, to look at the antibiotics that do that. And I think it was Dylan that came up with the Z-Pak, right, last time? So azithromycin fits into that category of targeting the 70S ribosome. We can break that down into a number of antibiotics that all inhibit protein synthesis. We can put them into their various classes, and we're going to begin with the aminoglycosides. The aminoglycosides, actually, their mechanism has been a bit debated, and the textbook coverage of aminoglycosides has changed gradually over the years. We now begin to understand them as affecting largely the 30S or the 30S ribosomal subunit, but specifically affecting how tRNAs seem to be able to bind. So it seems to affect the 30S ribosomal subunit, causing it to really mistranslate proteins. It's really effective against a lot of the Enterobacteriaceae. So remember that that's a large family of bacteria that includes things like E. coli, Klebsiella, but it also includes things like Yersinia pestis, the bubonic plague causing bacterium. So mainly gram-negative bacteria that respire. And of course, some of you had Proteus as your unknown, perhaps a clue regarding its ability to cause urinary tract infection. Proteus mirabilis, a swarmingly motile bacterium also capable of respiring. So these are the types of bacteria that might be most affected by the aminoglycosides. It's interesting to also note that sometimes these are given in combination therapy with a beta-lactam antibiotic because it seems that being able to open up the cell wall a little bit by targeting it first with a beta-lactam increases accessibility of the aminoglycosides. They can get in better and basically cause their inhibition of protein synthesis a little more effectively. So you might see them prescribed along with some kind of beta-lactam. Here are the examples. We already know and love streptomycin. Remember, we worked with it in the lab. However, it's not really one that you love taking. Streptomycin has quite a lot of side effects. However, if you have the bubonic plague, you're probably going to be pretty glad that you can go ahead and take streptomycin despite its negative side effects. Gentamicin is another one. And then finally, catch this, neomycin. We have now met ingredient number 2 in Neosporin. And in fact, this is where the name of Neosporin derives. So neomycin is only used topically, not very good with regards to its selective toxicity, a very low therapeutic index. So it is the second of the 3 ingredients in our topical ointment. So aminoglycosides targeting the 30S ribosomal subunit, so too do the tetracyclines. And I'm just straining right now. I can't remember who asked me last time about the tetracyclines at the end of class. But in any case, there are a couple of members in the broader group tetracycline, and it includes not only typical tetracycline, but also doxy. Have you heard of doxycycline? Doxycycline is given for a number of things. One of the things that the tetracyclines have been overused and misused for is the treatment of acne. I was on tetracycline for a very long time when I was young because I had severe acne, and it didn't do much of darn bit of good, though I reckon it selected for an interesting microbiome, right? And this is something that we have seen used in treatment of acne for a long time. It reversibly binds to the 30S subunit, so once again, inhibiting the small ribosomal subunit of that 70S ribosome. Another thing that it's used for is actually certain very unusual obligate intracellular parasites. For example, Rickettsia rickettsii causes Rocky Mountain spotted fever. So that insect-borne disease, doxycycline is sometimes prescribed to treat that. Also, Borrelia Burgdorferi, one of my favorite types of bacteria to say its name. Borrelia Burgdorferi is the one that causes Lyme disease. It's a spirochete that causes Lyme disease. And so some years back, I had gone kayaking up in the Saguenay Fjord in Quebec. It's near Quebec City. And it was absolutely beautiful, but it was incredibly teeming with insects. So when I came back, I got a little bit sick, and my lymph nodes were swollen. So I went into the doctor, and she's like, uh-oh, I'm going to give you doxycycline just in case you picked up Lyme disease, because Lyme disease actually will cause later down the road complications that can be very severe. So physicians are careful to prescribe doxy right away if they think there's a chance that you might have gotten Lyme disease. So it's something to maybe think about. So tetracycline, doxycycline are the common examples of that particular group. Lastly comes Dillon's Zithromax, the Z-Pak, because this category is the only category that we're looking at that targets the 50S subunit. So all of these target the small ribosomal subunit until you get to the macrolides, and then these target the large ribosomal subunit. Has anybody ever had walking pneumonia? Or know somebody who has had? Yeah, a couple of hands. Okay, good. Walking pneumonia is caused by Mycoplasma pneumoniae. So I think I'm actually going to write this down. So let's just bring up a couple of these, and then I'll write down. Mycoplasma. Does anybody remember from lab what it is that causes most cases of pneumonia? What bacterium? Not Klebsiella. Klebsiella can cause, I love the answer, Eric, because Klebsiella pneumoniae can cause pneumonia. Interestingly enough, mostly in older alcoholics, in people who are immunocompromised. That's where we see Klebsiella causing a number of cases of pneumonia, but it's more of a, it's a little more opportunistic. The one that causes most of them is the one that we look for when we're trying to find it using resistance to Taxose P. Streptococcus pneumoniae, yeah. Upwards of 90-some-odd% of cases of bacterial pneumonia are caused by Streptococcus pneumoniae. So true bacterial pneumonia, the type that sometimes puts people in the hospital, that is caused by Streptococcus pneumoniae. But walking pneumonia, the reason that we call it that is because typically you've got it and you're walking around going to class, but man, it's not fun. You really feel it. Yeah, it's not fun at all. But eventually you figure out, oh man, I need to be treated for Mycoplasma pneumoniae. But here's the interesting thing. Does anybody remember what this indicates about this bacterium? What does it lack? Plasm or plasma. Yeah, absolutely no cell wall. So when we think about the fact that this has no cell wall, we wouldn't want to treat this bacterium with what? What would be a real bad physician's choice in trying to... Penicillin, right? Bad choice. What else? Cephalosporins, right? Keflex, any kind of cephalexin, ampicillin, amoxicillin, any beta-lactam antibiotic or cephalosporin that targets the cell wall, bad choice. That would be a real poor decision. That would be a real incorrect use of an antibiotic, because with no cell wall, there's absolutely nothing for those antibiotics to target. There's no peptidoglycan present to try to stop the cross-linking of at all. So we wouldn't see those being effective. Yet, if we do target the 50S ribosomal subunit, of course, that's a pretty good choice. So something like erythromycin to treat walking pneumonia is a very valid choice, and maybe a Z-Pak, depending upon the situation. There's also another antibiotic in this group called Clindamycin, which actually, prior to understanding that fecal bacterial therapy worked the best for treating C. diff infections. Remember, we talked about the most common cause of antibiotic-associated diarrhea. People used to use clindamycin, but it wasn't very effective. So we're seeing a lot more effectivity in the kind of probiotic choice instead of the antibiotic choice there. But let's look at a Z-Pak, because of course we talked last time about the appeal that the Z-Pak has, because there are only how many pills? Like 5 or 6, right? Let's count them, because I've got a picture here. Pfizer was the original marketer, if you will, of the Z-Pak, and I believe don't you take 2 the first day? I think you take 2 the first day, and then you go in 2, 3, 4, yeah, something like 5 days worth of treatment. And so, of course, people aren't feeling better by the time they finish it, and so they continue to take the prescription, and we don't get misuse of antibiotics on that side of things, of people stopping their antibiotic therapy and that leading to the rise in resistance. Okay, any questions on the Z-Pak or just in general those antibiotics that target the ribosome and stop the action of the 70S ribosome? Yeah, Zuri. Yeah, I mean, her question is a good one. So there's 2 answers to it. Let's come up with both of them. So we use Neosporin a lot, right? All of us have it in our cupboard. We do use it preventatively, right? I put a little on this cut preventatively because I didn't want it to get infected. So her question is, with such a poor selective toxicity, why do we use it so much? Isn't it maybe doing harm to us? Well, why is the reason we use it on our skin? What allows that to be okay as far as selective toxicity goes? What's true of your skin? Okay, Philip, I can't quite, give me.
Well, it's not getting absorbed.
Yeah, okay, good. For the most part, we're not seeing it become, I like that, absorbed into the system. It's not entering your bloodstream, so to speak, and becoming toxic to your sensitive tissues, because, and somebody over here, Jonathan, was that you? Yeah, good. Yeah, our skin cells are dead. They're dead. I had a funny anatomy professor. He really was already retired. I'm probably already told you this story, but he really did a poor job. I kept wishing he would. I went to class every day so prepared that I could lecture. I kept hoping I would be obnoxious enough that he would say, "Do you want to lecture?" And I'd be like, "I thought you'd never ask." And then I could lecture. But he did say something funny. He said, next time you think someone's good looking, remember that they're dead. Right? Everything that you're seeing on the first layer, right? Our skin cells, they are dead, right? So the selective toxicity part is not so much of an issue when we're putting it on cells that are already dead and highly keratinized. They really, it's not causing that big of an issue. But that doesn't mean, could we still argue that that's overuse of antibiotics? Absolutely. And in fact, when I say, the more I'm sitting here yammering on about it, the more I'm thinking that it's a really shitty use of antibiotics, actually. Because what do a lot of people do with a half-used tube of Neosporin? Throw it in the trash, right? And then it goes off to the Laramie landfill, where it oozes out of the tube and exerts selective pressure, and then we see the soil microbes in that area becoming, well, I shouldn't even say becoming, right? Use the terminology, we are putting a selective pressure on those that are already superheroes. So the more we do use an antibiotic preventively, the more we do see the antibiotic resistance pressure, the selective pressure out there. So, that's a complicated answer. And questioning our use of antibiotics at all interfaces, I think, is a good one. And thinking about maybe whether there might be something that could be an alternative that maybe wouldn't be exerting so much selective pressure. It's a hard question because on the flip side, too, we also don't want a simple cut to become infected and have people running in to get treated with oral antibiotics for that. So I think there's multiple layers to the answer to that question, Jordan. Yeah, and that's part of the reason for combination therapy, right, is that we know that the effectivity on a given potential infection is going to be higher when you're using a triple therapy because it's likely that you're not going to see resistance to all three. That doesn't mean, though, that it's still not putting a selective pressure, right, for any given one. But yeah, it's a very good point. And one to keep in mind that sometimes we can increase effectivity of therapy by using multiple antibiotics in concert and also likelihood of treatment of a given infection without having to go to the next and the next and the next antibiotic. Yeah, Jake? Acne. Yeah, so the hope there is to inhibit Propionibacterium acnes. And I'm gonna see if I can jot that down correctly for you guys in case you're curious. I'm not positive on the spelling. Propionibacterium. I'm not sure if that's an I. Propionibacterium acnes is the name of the bacterium that causes acne. But again, this is also another interesting argument where when your microbiota, your skin microbiota, when it is in balance, when you have the right ratio of Propionibacterium acnes to other microbiota of the skin, then it's actually not a problem. It's only when that ratio becomes off that you start to see it causing acne. So it is a bacterial infection, but balance is really key there. And so there certainly now is a lot of conversation about maybe probiotic approaches to treating acne rather than the use of tetracycline over long periods of time. Yeah. Yep, exactly. Right. And so that's another point, right? We can't distill acne to only being caused by the bacterium, right? There are other impacts and other factors systemically that do cause it. There's also a huge link between gut, microbiota health and acne as well. So hormonally balanced, but still we know all of that is linked to our normal flora population too. Very complicated, right, that interface. So very, very good. Very good points. That might be, somebody maybe look it up on if you've got your tablet out. But is it right? Oh, thank you so much. Okay, good. But in any case, it might be fun to think about, what are alternatives and, has anyone noticed, like if you were on tetracycline when you're young, when your teeth are still, before you've gotten your adult teeth, they often will come in yellow because tetracycline has a yellow pigment to it. So if you ever see somebody who's older and has yellow teeth, they might have been because they were on tetracycline for a while when they were really young. Yeah. Let's move to drugs that inhibit nucleic acid synthesis. So some of the most broad spectrum antibiotics are those that do target DNA supercoiling, the packaging of DNA. We know that all bacteria need to package their DNA, so whether it's gram-positive or gram-negative, this is often an effective approach for treatment. The quinolones are a good example of this, fluoroquinolone being one example where they are hitting the DNA gyrase, for example, depending upon the organism. They're really effective on a wide variety of bacteria. That means also that it's effective on a wide variety of different kinds of infections. Remember that E. coli is the most common cause of urinary tract infections. So UTIs, Klebsiella, Eric reminded us, can cause respiratory infections. Neisseria causes sexually transmitted disease. Pseudomonas, we know, can cause a variety of diseases if there's an immunocompromised state, including skin infections. Staph aureus, we've talked about the skin infections and even systemic or even food poisoning. Mycobacterium tuberculosis, of course, causes tuberculosis. So we see this wide range of effectivity. One really popular or famous example is Cipro. It's what we call it for short. The long term is ciprofloxacin. So I know that Kara is a world traveler, and others of you as well. Have you ever gone long enough that you had to take antibiotics with you? Yeah. To Thailand, yeah. And was Cipro amongst those? No. It's a common one. Sometimes when you do go abroad for a long period of time, this is one of the antibiotics that you will take with you because it has such broad effectivity. So depending upon where you're going, you may not be certain that you would be able to seek treatment for a bacterial infection. So some physicians are comfortable with sending a patient abroad with Cipro or some other antibiotic. Do you remember what you had? Levaquin is another good example of a... Levaquin fits into this category as well, yeah. So it's often the one that you'll take, and sorry, I cut you off. Others. It could have been an anti-parasite too, like some sort of anti-malarial drug. Yeah. Yep. Yeah, a pack of varying things. Yeah, and I think this is another place for really sexy-minded discussion because, you know, on first note, you might think, wow, you know, that's really a misuse of antibiotics, you know, sending somebody abroad with something that, and asking them to say, well, the minute you think you might have something bacterial, you self-administer. But on the flip side, I spent a lot of time in China, and I know that I was really glad that I had it. And so I think it's not necessarily a misuse, it's just open to discussion. Yeah, Julia.
Well, I was going to say, like, I went to Spain
Yeah.
the week after I got my wisdom teeth out.
Yeah.
And I remember he gave me a stronger antibiotic
Because you were traveling abroad. Yeah.
I don't remember.
Yeah. And so that's always an interesting thing to discuss too, is that we often consider something like Cipro or Levaquin as being an antibiotic that we would reserve only when really needed. And that is because we don't want to put too much selective pressure out there, whereas we know the Z-Packs out there, everyone's got it, a lot of selective pressure with that one, holding onto or reserving something like Cipro for cases where we know it needs to work, right? And then making sure that you're going to be set to go when you're headed abroad. Drugs that interfere with cell membrane integrity, yay, we get to meet the very last member of our triple antibiotic ointment. So the last ingredient is Polymyxin B, which again is not selectively toxic. It targets membranes. So you might remember that we tested this against the 3 bacteria that we tested in the Kirby-Bauer assay. We looked at polymyxin and noted that it was effective against gram-negatives and even had effectivity against Pseudomonas. But it is not something you would take orally because it does impact both eukaryotic and prokaryotic membranes, causing the ion gradient to diffuse out of the cell. So as we summarize Neosporin, the triple antibiotic pack, you know, the action that packs is threefold. Number 1 is, what was the first guy in there? Bacitracin, good, 2. Neomycin, the namesake. And then lastly is our Polymyxin B. So that's the triple antibiotic POW, targeting cell walls, cell membranes, and protein synthesis. Okay, who has questions on antibiotics? I promise a little bit more discussion starting now. But if you have something, just, you know, fill in.
Is it possible that by using antibiotics, we're not just putting selective pressure on bacteria, but on our cells? Like, over time, would people become more susceptible to these infections?
Yeah, so this is such an interesting question because we say, you know, one of the teaching points, let me reiterate Eric's question, is he's saying, with antibiotic selective pressure, is it not just a selective pressure against the pathogens, but also selective pressure against us? That is, said another way, people always will say things like, I'm resistant to, penicillin. I can't take it, right? It doesn't work on me. And it used to be that in teaching, I would adamantly stand up here and I would say that is not the case, right? Bacteria are what become resistant, not you, right? But now we understand what? We are our bacteria. Yeah. So that's an interesting point that now when I answer that question is a little different than when I answered it even 3 years ago. Because now we do understand that what could be resistant within you? Yeah, your microbiome. So if you have experienced a great amount of selective pressure, if you've been on constant antibiotics throughout your life, that your microbiota could be carrying antibiotic resistance genes. Now, did anyone, yeah, you read the article, you sent me that article about it was the Yamamamo, right? That have a 40% increased biodiversity in their microbiota. But that was interesting because they actually found within some of their microbiome antibiotic resistance genes. And the interesting thing there to ponder is there's a population that's never come into contact with antibiotics. They haven't been overused and misused in their population, but yet they're seeing some antibiotic resistance tags there. Why do you think that might be? You pondered? Yeah, I mean, not so much because they're pretty isolated. Yeah. Yeah, you got it. You got it. And particularly in a population with that biodiverse of a microbiome, it's very much likely due to consuming a lot of prebiotic type foods, things that are very close to the earth, right? And eating in that way is likely exposing you to soil microorganisms, and those are going to have natural antibiotic resistance. That's a big part of the way in which the dynamic of the soil is established. So I love that, and so I think we can't wholeheartedly say that even when we take away our selective pressure of antibiotics, that we would never see, antibiotic resistant microbiota. But certainly, it's a very different reason for that. So, very cool. Let me ask you even some more thought-provoking questions now. This one's, I think, pretty straightforward, and then we'll get to the more thought-provoking. So, in general, which type of cell is easier to kill or inhibit with antibiotics? Gram-positive or gram-negative? Gram-positive. Why? Yeah, they don't have the protective outer membrane. They lack the protective outer membrane. But also, their most exposed layer is peptidoglycan. And there's nothing like that in the eukaryotic world. So having that as the most outer and exposed layer certainly makes it a little bit easier to target something that is uniquely them. So we could say in general, yeah. But we also know what do we also know about gram-positive cells? There's a very high population of, for example, MRSA, right? Antibiotic resistant cells. So, it's a bit of a trivial question with a more complicated answer. But absolutely, straightforward in the sense that at least originally they had that outer layer that was more easily targeted. Okay, now the more thought-provoking questions. Because of the rise in antibiotic resistance, many efforts are underway to develop new drugs. And so these are things that Jordan brought up, for example, combination therapies, right? Using more than one type of antibiotic so that you decrease the chances that you will be selecting for a resistant strain, because if there's a presence of resistance to one antibiotic, it's unlikely to also be present for another antibiotic. So using combination therapies is very possibly one of the ways that we can address antibiotic resistance. We're also working on developing new drugs. Linezolid, has anybody heard of linezolid or Zyvox? This is a new drug that was recently marketed to treat MRSA, so it is another line therapy. And Michelle, I'm curious about what you took when you had that infection. We'll have to see if you remember, if somebody has record or something. Yeah, look and see what it might have been that was used there. I mentioned the combination therapy. remember Sam brought up, didn't you, the augmentin, right? That's a good example of utilizing both an antibiotic and then the inhibitor of the beta-lactamase enzyme. So trying to inhibit the resistance at the same time as you're treating the infection. Yeah.
I actually text my mom.
Yeah.
She's a physician.
Oh, okay.
So she said that she normally uses Septra if there's no allergy, no sulfa allergy.
Yeah, okay, good. For after MRSA cases. Oh, that's interesting. So your mom, where does she practice medicine?
She's an internist.
Okay.
In Indiana.
In Indiana. Okay, cool. So that's possible that it was Septra. That would be taken orally. So sulfa, if there is no sulfa drug allergy, but we know, wait, who was it that was saying, Jonathan, right? That was saying.
She also said doxycycline.
Yeah, doxy. Okay, yeah, that would make sense too. So potentially, right, something orally used could have been one of those two things. Yeah, maybe so. Cool. Thank you. This is where I say, why in the world do we not want cell phones in the classroom, right? It's like, I mean, of course we do, right? This is what your mom's voice gets to be heard here now too, which is fantastic. So what else? Well, I want to talk to you just a little bit about a couple of kind of scary on the rise resistances. And I didn't get a chance to write these down this morning, so I'm going to do so with you now. But who has heard of multi-drug resistant tuberculosis or extensively drug-resistant tuberculosis, XDR-TB? Jinsey, have you done some reading on those? Yeah, oh, that's right. That's what your poster is. So tell us just a little bit about it, kind of a little background for everybody, maybe a little bit of, wet their whistle for what your poster is going to focus on.
So we were focusing a lot on multi-drug resistant tuberculosis specifically, but what's happening is the full dose of antibiotics is being used for tuberculosis. I think we read about it's recommended that you should take antibiotics for 4 to 6 months to be fully effective.
Right.
But it just, surgeons aren't taking them, or they don't have, or students don't have enough resources to be able to.
Accessibility is a major issue, right? Exactly.
Like in Russia, it's a big problem in Russia.
Right, exactly. And actually, I brought up a world map. For some reason, I couldn't find one any more recent than 2010. I don't know if you all have seen one more recent than this, but it shows, this is actually Doctors Without Borders. I'm going to show you that in a minute. But this actually shows what it is the proportion of cases of TB that are multi-drug resistant in particular regions. You'll notice that in some regions there isn't data available, so it's hard to know what's happening in many of those white regions. But one of the areas is in the Russian prison system that they're seeing a high number of these cases. And a lot of that, I think, is due to accessibility. There's certainly, it's very much a disadvantaged population, and they're not being treated or not having accessibility to a full course. And a lot of times when you can't complete the course, you're seeing that resistance. And so MDR TB, or multi-drug resistant TB, is defined as being resistant to isoniazid and rifampin. And isoniazid and rifampin are most commonly used specifically Mycobacterium tuberculosis. Now, what do we remember right off the bat is very interesting or tricky about treating Mycobacterium? What did we learn about them and specifically stain for in them? Yeah, perfect. They've got this layer of that waxy hydroxy lipid called mycolic acid in their cell wall. That is, they have acid-fast cell walls. That makes them a little bit difficult to treat, but it also does open the possibility for targeting that mycolic acid layer, and that is actually what isoniazid does. But these are antibiotics. But check this. We also are seeing cases of extensively drug-resistant tuberculosis, where that is defined as resistant to isoniazid rifampin, but also the second treatments, such as quinone, right? And then also, in addition, at least one of, and amikacin, kanamycin. I don't know if you guys can read this. Amikacin, kanamycin, and capryomycin. These are aminoglycosides, or at least kanamycin is an aminoglycoside. But overall picture there is that when you're talking about extensively drug-resistant TB, you're talking about something that is not just resistant to frontline antibiotics, but also second-line antibiotics. And this becomes exceedingly hard to treat, very, very hard to treat. So this being said, when we're talking about people dealing with MDR-TB and XDR-TB, sorry, my announcement, as you might imagine, it's horrible. And they may end up having to take as many as 20 pills a day. Yeah, crazy, right? And so what we start to get the feel for is why, and so Jinsey brought this up too, like why has treatment of TB been so difficult? Well, it's because you have to take these antibiotics for often 6 months to even a year. And I told you, I think about my TA who had latent TB. She had to be on a year's worth of antibiotics, and she didn't have a single symptom. Right? It was just latent. It was never going to, at least not in her healthy self, it wasn't manifesting. And so having to remember to take antibiotics for a year when you're not even sick, or you start to feel a lot better, it's really, really difficult. So this is actually a site that I thought might really interest a lot of you. This is a Doctors Without Borders site, and it's actually just full of blogs written by people who are dealing with XDR-TB or MDR-TB. And in many cases, these are folks who already have HIV. So they're dealing with MDR, XDR-TB as a secondary infection on top of that viral infection. And so if you wanted to jot this down, would you like me to post this on, I could post this actually as an announcement. I could go ahead and do that. And then if you have interest in getting in, I got literally taken by this today and ended up spending quite a bit of time just reading through some of the blog posts. But I think Doctors Without Borders is doing a really cool thing with this because they're bringing it up and talking about it and allowing people to talk outside of their local community through the blog, which is really neat. So another thing that can be done that's a sort of simple solution to antibiotic resistance like this is they call it DOT, D-O-T, DOT, which stands for Directly Observed Therapy, which literally means exactly what it sounds like. What? You watch somebody take their antibiotics, right? And what does that do? Yeah, like, you know, you just make sure that they're taking it, even though it's horrible for a really long time, but it just makes, and what a simple solution, right, to antibiotic resistance to just do something like DOT therapy, which is just watching and making sure that those antibiotics are getting taken. Questions or thoughts at all on that? I'll post this blog so that if you want to take a look, you can. Really quick before we leave, or did you have a question, Del? Yeah. Yeah.
There is a tuberculosis vaccination. Is that preventative of this, or is it evolved to a point where?
That's a good question. I know less about an effective vaccination. Yeah. Okay. We'll have to check on that. Yeah. And as you're leaving, if you all would think for me for a moment, why is it harder to treat viral and fungal infections? And as we see resistance there, why is it very hard to deal with, right? So you can ponder that and have it on your mind as you leave. So thank you and have a wonderful day.
I kind of was interested by this because my sister had a
Yeah.
woman with MRSA.
Yeah.
And she started Vanco, and
Yeah.
she had Vanco toxicity
Yeah.
in her kidneys. So
Yeah.
I just had a couple
Yeah.
questions. 'Cause
Yeah,
for
definitely.
infectious
It's such a
disease
horrible
doctor-
thing to have to go through. Yeah. Yeah. Where is she right now?
Oh, she's good now.
Okay.
She's good.
Yeah. Good.
She had
Good.
a 2-level lumbar fusion because the MRSA ate a level of her spine.
Yeah. Oh my gosh. Oh, I'm so sorry. I can imagine how hard that was for everyone in your
That'd be
family. And
interesting just to see
yeah.
what took on. So I'll be sending you.
Okay.
Hey, I actually, just on the polysporin note, I just had a question because I recently, I had this huge cut on my hand, and I got stitches, and they put me on, cephalexin and things like that, but also they told me to